Hello, welcome to Primetime Live with Next Level Prime. We are back with our monthly series that is meant to let our listeners hear about all things Next Level Prime. I'm your host, Dr. Karen Rakers. I'm Vice President of Next Level Prime, and I'm a family medicine physician. I've been with Next Level for about 9.5 years, and I am thrilled to have been involved with our Next Level Prime program since it launched almost 3 years ago. So, just as a reminder for our new listeners, Prime is an advanced primary care model. So, we contract with employers, which allows employees and dependents to have access to unlimited healthcare services at Next Level 7 days a week. We have a virtual care platform, which is combined with a large network of physical locations in the Houston, San Antonio, Austin, and Beaumont areas. And the care that is provided includes primary care, preventive care, chronic disease management, urgent care. We have health coaching, emotional wellness counseling services. We also include nurse care navigators who are there to help our patients with their healthcare journey and also help manage any referrals that they might need. We include most common labs and also routine vaccinations. And the best part is that all of this is at no cost to the patient. So no copays, no deductibles, and no surprise bills. So we're really trying to break down the barriers to care, including cost and convenient access. Today, I am honored to have Mike Avenevoli, Managing Director at Higginbotham, on the program. Mike has been a great partner, and he is a wealth of knowledge and experience, and he's here to share all of that with us today. So, Mike, thanks for joining.
Well, thank you, Dr. Rakers. Excited to be here. Thank you for the kind introduction.
Yes, very, very happy to have you. So let's just start by having you kind of tell us about your role at Higginbotham. What do you do on a daily basis?
Yeah, well, I'll try to condense it. So I'm managing director here out of our Houston office. And, I primarily work with employer groups, somewhere in the ballpark of maybe 50-ish on the smaller side up to maybe 1,500 on the larger side. And really my emphasis, while we work with them all things employee benefits, non-medical included, really the emphasis is on the medical side. And, my passion really has been, trying to help employer groups build different programs that do exactly what you just mentioned. That's remove barriers of care for employees, help reduce costs, and then control that cost long-term for employer groups.
Awesome. I know that you work kind of closely hand in hand with a group called Mitigate Partners. Can you tell us a little bit about that and what that looks like?
Yeah, absolutely. So Mitigate Partners really we're more of what I would consider like a national alliance of different independent advisors. We have folks from the Higginbothams of the world all the way to more small, 3-4 person agencies. But really our focus is finding ways to create employer built healthcare plans that are ultimately better programs, better benefits, and they're helping employers lower cost. Part of our main focus is to collaborate with each other, solve different challenges, share best practices, and then really develop resources to better serve all of our clients throughout the entire U.S.
So there people that do the same thing you do, but instead of maybe competing, you're actually working together.
Yeah, 100%. I mean, on paper, we would look like competitors, right? I mean, we are competing agencies,
Okay.
but we're like-minded. So, we've come together and said, hey, we know that we're trying to solve for some of these issues in healthcare. And so we just really believe in that old saying, iron sharpens iron. And so if we can work together, we feel that we're going to be better out in the marketplace, better serving our clients.
I love that. You don't always hear that in, competing markets. It's more like we're going to keep our ideas to
Yes.
ourselves.
No, you're absolutely right.
Well, I love that also because, you've kind of mentioned you're trying to solve these issues. What kind of, struggles are employers having when it comes to healthcare? What are we talking about here?
Oh boy, there's a lot of them. Typically I try to break them down. I try to keep to 5 bullet points. While it's not all encompassing, I would start by saying rising costs. I mean, that's a huge one, right? Both medical side, pharmacy side, every year, specifically on the fully insured programs, groups are getting anything from what's considered a trend increase, which is like 8 to 10%, upwards of, 20, 30% increases, right? So rising costs is just a major issue. Then we get into access, so that's the second one, access for employees. And access isn't just, hey, do I have a network, or do I have the ability to access a hospital or a physician? But it's also access based on financial, right? That, hey, can I afford to get the care that I need, right? We have this terminology out there called the fundamentally uninsured, which means they have these $5,000 and $6,000 deductibles, no first dollar benefits. And folks are expected to pay all of this money out of pocket before insurance pays a penny of it. And so ultimately they can't get the care they need because most folks, let's face it, just don't have $5,000 or $6,000 laying around. So, which leads really to the next bullet point, and that's going to be the increase out of pocket, right? So, as employers get these renewals, they get really tough decisions that say, hey, do I increase deductibles and max out of pockets in order to quote unquote reduce premium? And in doing so, all they're really doing is shifting costs right back to those employees, right? And so, it just gets to be, a challenge year over year until all of a sudden you get to those $6,000 and $7,000 deductibles and you can't shift cost any longer, right? The last two I would mention is this is probably one of the most important, and that's the perceived inability to make a difference. I talk with countless CFOs and CEOs and HR folks, and it's, well, hey, my broker says, it is what it is, and we just had a bad claims year, right? And so the perception out there is I can't really do anything and I'm just kind of stuck. And so then I would say, well, how do you overcome that? And that's going to be the last bullet point I would say. And that's investment of time. Employers don't take enough time to invest to understand how to control costs. They simply passively manage these programs and they expect a better result the following year without putting any time to really understand how do we manage our cost. So those are really the 5 bullet points that I would say are the most pressing that we see in the marketplace.
Yeah. I just, kind of piggybacking on your access and out-of-pocket cost. I think that kind of relates to what I kind of see as employers are providing health insurance. We talk about that as health care, but really providing insurance is not providing health care because people still can't get it, right? Like those deductibles are too high. They can't get to the doctor. They don't know where to go. Like whatever those barriers are, I think we all need to start thinking about the provision of health care is not the same as just giving people access to health insurance. It's completely different.
100%. So one of the things, it's funny you say that because when we talk to employer groups and they say, hey, if we invest time, they ask kind of what's your process? And I said, well, the very first thing we need to get across is we need to get you to shift your focus from being a purchaser of health insurance to becoming a purchaser of health care. Absolutely. And as soon as you understand that you can become a purchaser of health care, well, you keep the insurance for the really big stuff, the nasty stuff, right? Yep. But the day-to-day stuff, just like under the Prime program, it's, hey, we can be a purchaser of health care, bring back that physician-patient relationship and remove barriers to care and also incorporate significant savings back to the group. So it becomes that win-win.
I've probably said this on the program before, but I'll say it again. My analogy is like car insurance, auto insurance. We buy that not for like oil changes. We buy it for your big accidents or things like that cost a lot of money that you don't have. But for your routine maintenance, it's kind of,
that's it, right?
That's not what it's for. Yeah.
Nobody's going to go out there and ask, Travelers or State Farm or Geico or whoever they're using to get some sort of a quote to say, hey, I want my oil changes and my tire rotations covered under my insurance policy. Like, you just wouldn't do that. So why do we incorporate things like primary care and our day-to-day type healthcare into an insurance policy? But that's one of the shifts that we need to have employers make in order to go down a different path to control cost.
Absolutely. So, you've got your 5 bullet points of what are the problems. So tell us your approach. How are you kind of helping employers solve these problems?
Well, first off, it's not easy. Gosh, it seems like we always run into the employers that say, hey, we have all the issues, but then as soon as you can actually pinpoint the issues and come up with the objectives that you're solving for, well, suddenly they don't want to be solved for, right? So I'm going to go back to the previous question and say the very first thing we do when trying to help folks solve for this is we need time. We call them employer built plans, and employer built plans are really, they work best. We can build them the best when you have the C-suite and the HR team both invest time to really get like a comprehensive understanding of how the healthcare system works, right? And once again, it's that shift from purchasing health insurance to becoming a purchaser of healthcare. One of the analogies, I'm big on analogies to try to help folks relate, because healthcare can be really, really complicated, right? So we use this analogy of just building a house, right? And everybody understands when you're building a house, you got to have a foundation, and you throw the studs up and put the bricks and then the roof on top, right? So what we really say is, hey, as we're building a house, first off, do you want to build a house on sand, or do you want to build a house on a solid concrete foundation? And it's a rhetorical question. Everybody's always going to say, well, of course I want to build it on a solid concrete foundation, right? So, okay, whenever we help an employer group build their plan, the solid concrete foundation is some sort of a value-based primary care program, because when you think about how healthcare works, where does it start? Healthcare starts at the primary care physician. And so if you can then bring back that patient primary care relationship and remove third-party payers, i.e. the insurance carriers, out of the equation and allow physicians to practice medicine, well, now all of a sudden you've built a fantastic foundation that you can build off of. Should they need other care, you now have that physician that's truly in the weeds and truly can be practicing medicine with them. So there's two things.
That warms my heart.
Well, then I would say as we build that house, so to speak, sticking with that analogy, one of the things that we're really big on is removing barriers to care. I mentioned that a little bit earlier. It's not just a barrier to care saying, hey, I need to talk with my physician or see a physician, but it's a financial barrier to care, right? We'll talk about some success stories later on, but I'm big into developing plans to give folks access specifically to primary care along with other avenues at $0.
Yep.
We don't want them to have a financial barrier. If somebody's got to go see a doctor, we want them to see a doctor. I'm not sure in doing the 16 years that I've ever ran into anybody that's like, hey, I love going and seeing my doctor like on a daily basis. So I'm just going to rack up, claims because I truly want to go into that doctor's office every day. Like It just doesn't happen, right? So we want to remove that barrier to care, that when they need care, they can get it. And then I would say really lastly is once again, sticking with the house analogy, once we have that foundation, we have the value-based primary care in, we've removed some barriers of care, then what we want to do is kind of put the bricks in place. And those bricks are going to be specialized programs like centers of excellence, oncology care, navigation through the plan. That is of the utmost importance. We just took over recently a home builder here in the Houston market. And we said, hey, your plan's actually doing pretty well. I went to the house analogy. I said, but here's what you're missing. You're missing the mortar between the bricks. And what I meant by that is you're missing the navigation to steer towards these great programs. And so the employees were crazy confused. Do I go left? Do I go right? Do I go up? And you got to really have somebody that understands to be able to navigate. And long story short, they are absolutely on the right path. We put a navigation program in, and in the first 2 weeks, over 100 folks reached out for assistance. And so we said, hey, there's the proof, right?
Well, and I think just like it's confusing for the employers to grasp like healthcare, health insurance in general, the patients, the employees, it's very confusing for them as well. So as much as you try to educate and handhold in the moment, they're likely to forget that they have access to programs and things. So you do need that layer where they're, getting someone to basically say, hold on, stop, let's look at how we can do this in a easier, more effective, less
That's
cost
it.
way. Yeah.
So we've all been really conditioned. I'll kind of end this part on we've been conditioned of what I call the Black American Express card. And it's, you pull out and you have one of the big four logos, Blue, Aetna, UHC, Cigna.
Yep.
And it's, you go anywhere and everywhere. You don't shop around. You don't know, quality, price. It's,
Yep.
hey, this is where my friend next door 8
Yeah.
years ago got a knee surgery. So that's where I'm going to go. And you're
Yep.
like,
it's hard to be a consumer because you don't have the information.
that's it. And so that's part of that whole shift on when we put these programs in. We give that ability, but then we also kind of force the hand a little bit through steerage to say, hey guys, we're not going to take away the American Express card yet. Down the road, maybe, but we're going to give you a debit card that's actually going to pay you a dividend, if you use it correctly. So it's actually better.
Yeah.
So,
and to point out too that the doctor's making the recommendation about, hey, you need a specialist referral, hey, you need an MRI, hey, you need a surgery. They don't know either. The doctor making that recommendation doesn't know to say, hey, check, with your plan to see what programs are in place. They just say, go down the hall to my MRI machine, or go to my, friend who's the surgeon across the street.
I feel like you've heard me say this in some of our open enrollment meetings, but we say the most expensive place to go for healthcare is down the hall.
Down the hall.
and all we mean by that is you're with a specialist, or you're in the hospital system.
Yep.
And they say, go down the hall. It's like, no, stop. Don't go down the hall. Don't do it. It's bad.
Yep. That's right. Well, so let's kind of go focus on the primary care part. Let's talk about your foundation. So what are your thoughts on the best way to approach primary care?
Yeah, well, first of all, you got to break apart, what has primary care become? Okay. So, I mean, if you go back to the 70s and 80s, primary care is very different than where we're sitting in 2023. And so the first thing you got to understand is fee for service, okay, which is your traditional, Blue, United, Cigna, Aetna, you got the logo on the ID card, you're going in. Most of those primary care physicians have what we call a patient panel of, say, 2,500 on the lower end, upwards of maybe 3,500 on the high end.
Yep.
Okay. And so traditionally speaking, they're going to get to visit maybe, if you're lucky, 5 to 7 minutes. It's really hard to have a great patient-physician relationship in a 5 to 7 minute visit. And then you have to understand the underlying interest that, they always say, I'll pick on like blood pressure, for instance, right? Well, if you got to go in for a blood pressure check, well, why do you need to go in every 3 or 6 months for them to slap a blood pressure cuff on your arm? You can do it at home and self-administer. But they need you to come in because the revenue stream is you stepping foot in that office, paying the copay and billing insurance, right? So this is all part of the education process and understanding. Now, it doesn't mean any of those doctors are bad doctors. I will never say that. What it means is they were a victim to the healthcare system and really what's been created to where they're forced that they just can't spend more than 5 or 7 minutes, and they have to continuously be driving revenue back into their office.
Yep.
So with that understanding, right, we say that primary care is that foundational component of a well-built health plan. And so, when we put a solid foundation in that, in that health plan, what we're doing is some sort of value-based primary care program that we're removing insurance, okay? Whether that be, call it a capitated fee, a membership model. I mean, at the end of the day, they're all, similar type of methodologies, but you're really saying, hey, we want to go direct to that physician and remove the insurance carrier so we can now have that patient-physician relationship, right? Yeah. And then I think, the last couple of points of that is when you have that physician patient relationship, what you're really allowing to do, I'm going to kind of now go back to more of a sports analogy and say, you're allowing that physician to play quarterback. Yeah. You're allowing them to be in charge of the offense of your healthcare. and to then, guide you and steer you where you absolutely need to go. What you're also doing by having that relationship is you're able to get better access. You pick on the Prime program, right? So we know with you guys, if somebody needs a physician, they have 24-hour access, right? And part of the beauty of that is, while it may not be the physician they saw last week or 2 weeks ago, all of their medical records are right there in house. So whoever they're talking to is going to be able to pull up all notes and all records from the previous visit, and they're going to be able to have a great understanding. See, not to necessarily knock on the telehealth services, but when you call the teledocs of the world, you're speaking to some random doctor within that state. I mean, they could be here in Texas, right? We're in Houston. They could be over in like Amarillo or, on the far west side of the state, but at the end of the day, because they're in Texas, that's who we get on the phone. They don't know me from Adam, but yet they're in charge of prescribing whatever medication it is that I need, right? And so you miss that holistic, opportunity to treat the patient, that you're calling in for one thing, but hey, after looking at your records, it actually may be something else that we need to take a serious look at, right?
Yeah.
So all that to be said, primary care, absolutely, that's where everything begins. And when you have a great value-based primary care program, then it's really easy to put the studs and the studs up, the bricks together, and the roof on top.
I have to mention with the telehealth, the other big, issue that we see, and our solution under Prime, is that, you're talking to someone in where did you say, Amarillo? And I'm in Houston.
Yeah.
They don't have a place to have you go also in person. If they really think that you actually need some testing or an exam in person, you're kind of stuck starting over from the beginning when you have to go in somewhere, whether that's, a random urgent care or ER or wherever it might be. So, under the Prime program, that's one of the unique things I think that we have to offer, is that we do have all of our locations that if we're on the phone with somebody doing a telemedicine visit and we think they need an x-ray, we can just say, hey, go down the street.
Right.
And, they already know what we're talking about because it's in your record, and it's smooth and easy. So.
Well, yeah, because in a traditional telehealth program, they're going to say, well, go to urgent care or, go to the emergency room. You're like, I have a sinus infection. Do not go to the emergency room, please.
Yeah. Well, that's a whole nother thing we could probably talk about, is
I know, that's a whole different segment, right?
A whole different segment. So, obviously you seem to kind of have a good understanding of what the issues are and, how you are approaching helping employers solve some of the problems. I still feel like employers can be really hesitant to kind of make the switch and adopt some of these types of solutions. What do you think is going on that's preventing, employers from jumping on board?
Yeah, I think it really becomes a lack of understanding and hesitation to change, right? Just as humans, we're all accustomed to something, and then of course, you drive down here in Houston, you drive down I-10 or 59, or one of the loops, whichever one, 610, 8, Grand Parkway, whoever, you see billboards all over the place, right? And you have these carriers with billboards, the hospital systems with all these billboards, and all that costs a lot of money to put that up there, right? So it's the marketing. What we're told is that, hey, you have to do something a certain way, and this is how the system works. That goes back to what I previously said, that if an employer group really wants to make a change, they absolutely have to invest time with an advisor that understands the healthcare system to be able to start peeling back the layers, breaking it apart, and saying, hey, how do we then piece it back together, but put it back together to where it works in your favor, not in the favor of a BUCA, a major carrier, or even some of these hospital systems. And that's where it just gets complicated to try to explain that in a very short period of time. So When employers invest time, I will tell you, we have a couple of dozen clients that have all taken the time. Some of them, they invested 2 years before they made a switch, right? Just a lot of education, a lot of really understanding, getting just familiar with it. But I would also tell you, I don't have a single client that would say, hey, Mike, we want to go back to a traditional health plan. Not a single one of them would ever raise their hand and say that, because if they did, we could always take them back. But we have, it's better benefits at a lower cost, and it's easier to navigate. I mean, when you start putting that together, who would want to go back?
I would think those employers that have implemented would have some very upset employees if they tried to go back, because they've become accustomed to having that better access, those, lower costs.
So I was literally talking with an employee the other day that her spouse just came on one of our plans, and they have a value-based primary program in place. And the spouse was just ranting and raving, going, I had no idea that I could get this much access. Matter of fact, the first time they went and saw a physician, they were there speaking with that physician for somewhere close to like an hour. And then they were able to have, follow-up calls. At the end of the day, when you have that kind of access to your physician, it changes your whole healthcare. I mean, I won't go down the rabbit hole of wellness plans, but we always tell folks, you really want a great wellness plan? Let's put in a value-based primary care program and allow your primary care physician to be your quarterback of your wellness plan. And then if you want to keep a traditional wellness plan, do it more, to appease the employees, but not to necessarily expect an ROI or major changes in behavior. And so value-based primary care at the end of the day is the absolute foundational component of any well-built plan.
So how do you think that in and of itself, implementation, value-based primary care, how does that impact the bottom line? Because I think a lot of times the employer, that's really what their focus is. Like, what's my cost? What does it do for my
Well, so what you're really doing is I'll just use the membership model fee for a second. So when you get into a membership model, what typically hits the CEO, CFO first is they say, hey, here's a new added expense, right? So I now have to take on X amount per employee, whatever that amount is, and that's going to add to my bottom line. What they're missing in that equation is that what you're doing is in a self-funded plan. I think it's important to understand when you build a plan, it has to be self-funded. You can't build a fully insured plan. But what's missing out of that thought process is that you're moving claims that would be typically over here in your claims bucket, and you're now moving them into this membership fee. And it's like, well, hey, wait a minute. If we're going to pay out like easy numbers, if we're going to pay $20,000 a year in membership fee, but yet we can move $50,000 off of our claims. Well, gosh, man, I'm not a mathematician, but I'm telling you, that's a true $30,000 savings. I mean, all we did was we took, instead of spending $50,000 out of this bucket, we're spending $20,000 over here. So at the end of the day, you're netting out a savings of 30. It's just you spent the dollars out of a different bucket, but you still save 30,000. That's where we just call it healthcare financing, right? That's part of the education to CEOs and CFOs is to understand, hey, you're spending these dollars. Now what we're going to do is break them apart and help reallocate the same dollars being spent, but let's do it a little bit more efficiently. That's going to help your employees and you long term.
Yep.
So
absolutely. Well, I'm sure you convince people by sharing some amazing success stories. So let's maybe close with that. Why don't you give us a few of your best wins? What have we seen?
Yeah. Boy, I could spend an hour just going over wins. I'll keep it a little bit more high level as what's the bulk of the wins, right? So first off, every group that we have, not a single one can honestly say that they've increased deductibles, max out of pockets. Every one of them has decreased. Okay. And some have decreased 60 and 70%, right? They were starting at $5,000 deductibles and they're down to like $1,500.
Yeah.
That's huge,
That's
right?
Yeah.
We're going the complete opposite way of the trend in the market. Enrolled members, have access to care without any type of financial burden. I mean, we literally, in the bulk of the plans that we design, we love to go out to these open enrollment meetings and hear the feedback and everything from employees to say, yeah, I had all this done this year and I still spent $0 because, 90% of all medical care, the way we design these plans, everything from primary care all the way up into surgeries and everywhere in between, labs and imaging and physical therapy, the whole 9 yards, we can make those at $0. We just gotta build the plan the right way. Okay. So removing, that financial burden, we have a lot of folks that have $0. And then lastly, every one of these groups have also given back to the employees. We just call it the dividend, right? That as the plan performs well, which they all are, we'll take a portion of that and let's give it back and let's reduce the employees out of pocket or per paycheck premium cost.
Yeah.
So now they have, just to summarize that, they have most of them a $0 deductible, $0 copay type program for 90% of medical services. We have lower deductibles, lower max out of pockets. And oh, by the way, we're paying less per paycheck.
Yep.
And oh, by the way, the employer's paying significantly less, which means when we get our raises every year, we're actually truly getting a raise and not taking that 4, 5, 6% raise and putting it straight back into medical premiums. So all around, those are the high level success stories.
Yeah.
And of course, we have dozens upon dozens of individual success stories. And frankly, I love the phone calls. Not that I love to hear folks crying, but when I get the person on the other end that is just choked up because they're like, this has saved us, from the aspect of, I got the care I needed when I needed, and I have no financial responsibility. And it is honestly saving our lives, right? And those are the phone calls and the emails that keep our team going every day. So,
well, and rightly so. I mean, because again, those are just things that you don't hear about in healthcare and medicine. I'm a doctor. I've been practicing medicine for over 20 years, and people are not talking about how they didn't have to spend a lot and had a good experience, in healthcare. So I think that's it. You've solved it.
Well, it is a daily struggle. We're trying, and hey, I'll end in this, right? Is we always tell our groups, we're never going to get it 100% right. I mean, it's almost impossible, right? Healthcare is evolving. I mean, every year there's something new coming out, new to the market, new rules, new regulations, new compliance. So all we simply say is, going back to that house analogy, is, hey, once you build that customized house, the employer built plan, you may have to go in and do a small remodel, right? Or another way to say is, you may just have to come in and optimize that plan. It doesn't mean that you tear it down and start from scratch. It means you slap a new coat of paint on the walls. It's really not hard in comparison to building a new house, right? So we're not always going to get it right year one, but in subsequent years, we just do small remodels and continuously make it better and better. So.
Awesome. Well, thank you so much. I feel like I want to go build a house now. So I think that we succeeded in our conversation. So, all right. Thanks everyone for joining Prime Time with Next Level Prime. Thanks, Mike, for joining, and we'll see you all next time.
All right. Thank you.
Bye.